Okay. Brevity is the soul of brilliance. Thank you all for being brilliant and moving and summarizing thousands of papers in your 5 minutes each. I mean, we gave you an impossible job, and you did it extraordinarily. We're going to breathe after this bit of speed dating and then open it up to questions. Apparently, if I was wise, I would call on Dr. Leshner first.
You may be sorry. So, another fabulous panel. 3 things, all related, have to do with counterproductivity, and many of you mentioned much of them, and I think it's a very important question, and I'm not exactly sure how we can help with it, but we better. You ready? So somebody said, the first point of contact is often residential treatment programs who, attitudinally at least, are anti-medication treatment. Notice. The second is 2/3 of drug courts don't allow medication treatment or don't recognize medication treatment. The third is that Narcotics Anonymous, where we tell people they can or should or must go, I don't know the answer to that, also is anti-medication treatment. Why are we shooting ourselves in the foot if those things are true? And is there something we can do to help get around that? I mean, besides, say, medication treatment's good, but it's a really scary thing what you just said. I hope that was clear.
Thank you, Dr. Leshner. You know, this has been an area of frustration, I think, as a clinician. I mean, I've had patients who have died or had non-fatal overdoses because they've been forced off of their medication, who've had to make choices between housing or medication. We know from, and you'll hear more from Dr. Rich tomorrow, I assume, about criminal justice and people being forced off of medication there. And in fact, about 1/3 of overdoses occur within 12-month proximity to contact with the criminal justice system. So this is a major point of intersection, yet many people who've had criminal justice involvement will tell you that they don't want to be on medication, something that we know will save lives, and the reason they endorse is because they don't want to be cut off and go cold turkey while incarcerated. How can this committee, perhaps, and this panel address these issues? Because often it's the patients who have to address it, and while they're looking for housing, they aren't going to, try to file a complaint somewhere. Is to get clarification within federal law, the Americans with Disabilities Act, the Fair Housing Act, that specifically calls out these medications as being, people who are on these medications as being otherwise qualified individuals under these acts. And to attach dollars to it. I mean, I loved when SAMHSA, for their drug court grants, said if you're going to be a contractor for this, you will not deny services to people who are on medication. Now, could that be worked into the federal block grant? I don't know. But these are perhaps mechanisms. And NIDA, at least for the tobacco world, has a research portfolio on the policy impacts of tobacco regulation, and maybe there's an analogous line of research to be done related to these medications and opioid use disorders.
Mentioned that the sober houses ban people on medication also. And this has led to an enormous amount of death and destruction. Now, you can certainly make a case that a house where the focus is on abstinence does not want to have people who are actively using, i.e. in full relapse. But that is not the case for people who are stable on medication. And I think the only way we're going to get through this mess is by teaching people that addiction and dependence are not the same thing. Addiction is compulsive use despite negative consequences. This is bad. This causes harm. This makes your life a mess. Dependence is needing something to function. We all need something to function. And unless we get that clear to people, I think people secretly see first of all, if you don't make that distinction, then medication is substituting one drug for another. It literally is. And if you also don't make that distinction, people think that you're kind of hiding something from them about these medications. They know that people can sometimes get high on them. They don't understand tolerance until people can get to see that, okay, addiction's this compulsive thing, dependence is just needing something. If we can get to that, I think we'll go a long way towards reducing the stigma on medication and to helping deal with these issues around housing and around the prejudice against including people stable on medication in 12-step programs or whatever. I should also note that it is, if the person has any type of alcohol issue, sending them to AA is safer than sending them to NA, because AA does not have an official policy. It basically says it's between you and your doctor. So that's just.
I think the main reason why those programs are still in existence is because there is funding that goes to them. So as long as there is a funding, and unfortunately some of the federal funding goes to fund those programs, they will exist. And I think the main strategy, I think SAMHSA has certainly been changing dramatically that in the last years, but I think that's the main reason why those programs exist, even though they are not only ineffective, they are dangerous in many cases.
Michelle, you going to go?
Sorry.
Okay.
I just want to echo what Adam said. And the funding hides in different places. Like sometimes the funding isn't from SAMHSA, sometimes the funding's from HUD, or places you wouldn't think that normally are going to be places where your patients who are addicted may be needing to live. But there are lots of different places, and what it ends up doing is it ends up so that we don't have all the levels of care that we need to treat patients. So if we could potentially treat someone in a shelter, and that shelter or facility is getting HUD funding, but then they have a policy that they don't allow medication treatments for opiate use disorder. They would allow any other medication, but just not medication treatments for opioid disorder. You're putting all of this burden on a level 1 waivered doctor in office-based practice to treat them in that care. And this is happening also at the higher levels, like 2, 3, 4, if you're looking at ASAM's level of cares, where these places are supposed to be helping us with all the comorbidities, medical, psychiatric, the recovery supports, but yet they won't allow the medication. So what it ends up feeling like is, in a lot of rural areas where there are very few physicians, is that you're treating some of the sickest patients in a level 1 facility, and the patients aren't doing well. And then the doc or the MP, just their hair goes out, and they just say, we can't see you anymore. And so I think that's also part of why our retention is so low. We're putting a lot without having access to all the levels of care. You have so many patients in rural areas that aren't Vermont's, with really, really ill people. And then when you have them then want to have burdensome prior authorizations, and you're headbanging a lot of the times, and then if you're not reimbursed for it, we have doctors who will just leave the state. So I mean, we just had I'll just share a story. We just had our CHISAM chapter meeting this past weekend. So all the doctors were phoning in or calling in, and one doctor shared that he had a practice, and 2 of his other prescribers of buprenorphine decided to leave the state. And so he all of a sudden had to take on their panel. Luckily, he had a 275 waiver. He took them on, but then that flagged something in our state prescription monitoring program, where he then got audited, and he had to hire a lawyer and spent $16,000 defending his practice. He was fine, but he didn't do anything wrong, and here he felt that, and then that has ripple effects on the rest of the community as we're trying to draw more providers in. So,
Right.
I wish that I had a simple answer to Alan's question about why are we shooting ourselves in the foot. But I would like to be hopeful because I've had some progress. I mean, I have been going to therapeutic communities, on, ethics boards, things like that, and also working with judges for drug courts. I even invited a drug court judge who was initially against medication to one of my IOM committees that I chaired, and he gave a really nice presentation, and he eventually got turned around. As a matter of fact, my experience with these people, whether it's AA because we have medications for alcoholism too, or NA, or in many cases it's a combination, they can be convinced, especially there is an appeal of naltrexone because the goal of naltrexone ultimately is stable abstinence, which is really hard. I mean, we've essentially, since I got into the field, we've sort of changed with agonists. It used to be that we were trying to stop methadone as well, and I did a study on double-blind detoxification. Believe me, even small decrements, we had all different ways of detoxifying, but ultimately the shift has been keep people on like insulin for diabetes and show that when they're on methadone, they can drive a truck or a subway car, things like that, and they're not spaced out. But we've had pretty good success in convincing judges and some therapy communities. So there is a therapy community in Pennsylvania that I've been working with for years, and now they do exactly what you would like them to do. They give medication-assisted treatment, either methadone or buprenorphine, naloxone, or naltrexone depot. So I just want to say I don't have any, I have a few dramatic successes where, because it just makes common sense to me that if you add the benefits of residential therapeutic community treatment to medication, they shouldn't be versus one another, and this is my pitch. And I don't want to mention the name of some of these programs. Maybe I don't want to be commercializing, but I have had some of them change this policy, but it's taken me many years to do it.
Anybody else from the staff?
If I could just add, so if we had a treatment in medicine that we would send an individual with lung cancer to a center and they got a treatment that wasn't very effective, and then there was another center they could go to with a different list of medications, and they got treated and they had a much higher success rate, the science would tell us that this is a more beneficial treatment. So one of the things that I think happens with residential programs, and this is to this point, is that people just don't know. It sounds good. There's lots of good advertising. What's happened in the state of Vermont, and I've seen it happen in other places, is that the state Medicaid, because we expanded Medicaid, that's something we haven't talked about, is that we're a Medicaid expansion state. If you remove all barriers to treatment and you let the people who need the treatment decide and they talk with their feet, what happens? Okay? Our residential admit rate is no more than 2 weeks, and you have to be approved by Medicaid to go to residential, because our belief is that this disease is easily treated in an outpatient setting. Why send people for 2 weeks somewhere and then they come out without medication? It's almost malpractice, because we know the disease will kill you. So why do we keep funding situations for a single disorder that we know responds to medication? The only other thing I would say is that in states that have judicial courts, one of the things I would advocate is that the physician leaders around the country who are addiction specialists need to get involved with the judicial system to tell the judges what we do, what treatment is. I don't need a judge to tell me how to treat somebody with a disease. I need to be able to tell the judge, this is the evidence that we have, and show it so that they get a better understanding, and then they make different decisions based on the evidence.
I want to add one thing here that I just want to get into this discussion, which is that with medication treatment, we need a variety of thresholds We need it to be the case that if I just want to show up and get a dose and I'm going to use tomorrow, I can do that. If I just want to come for a couple of days, whatever it is, you know, the fentanyl situation is so deadly. We are losing wonderful people every day, and the trauma in the workforce is another whole thing among people who are working with people on the streets. I've just been out there and seeing people, but it's like, we have a drug that can save your life, but we won't give it to you unless you jump through these hoops, and therefore you will go and use fentanyl. Let's not have that happen. Let's have it that if you need to go, if you can go to an emergency room, if you can go to a needle exchange, if you can go wherever it is and get treatment simply as harm reduction, not as maintenance, not as anything more fancy than that, but then you could get, you know, once you come for a couple of days, oh, this is a nice place, maybe I do want to stabilize, maybe I don't want to be homeless, you know, you can work from there. But I do think that if we keep sort of smushing it all into the same thing and assuming everybody is in an abstinence goal or in a stabilization goal, then we, you know, we don't have a system where, like Hub and Spoke, you can go from, you know, different intensities of care as you need and as works for you.
Thanks. I want to make sure we get time for all the questions. So I've got Laura Chinzano, Walter Scott, Huda, Colleen, Sean. So we'll start with Laura. Thanks.
So I just wanted to call on the collective expertise about decision-making with regard to what medication to prescribe. So I'm going to assume that patient preference is in there. So in addition to patient preference, what are the criteria that you guys use to prescribe one medication versus another? Or no medication?
So I'd like to speak to that for a minute. One of the things that's very fascinating about that question is it the medication that's important or is it the setting? Because we know that there are people who could take office-based methadone, they could take office-based buprenorphine. And I think what we've seen is, how do we decide the intensity of your need? So if you go to, we have a triage tool that we use to kind of determine if you're a cocaine user, if you have chronic pain, if you're a benzodiazepine user, what medication should we use and what setting should it be in? So I would like to say there's two parts to that, the setting and the medication. But it's fascinating, and I'm sure each of you can share that most patients that we see have tried buprenorphine. They've tried it. Some of them are already inducted on it. They've been taking it for a while. And then you have a conversation about methadone, and they're immediately like, there's no way I'm going to take it because I know somebody who didn't have a good response. Or they're on methadone, they've been taking methadone, which is much less prevalent in the state of Vermont in terms of diversion. I think you pointed out very little diversion generally, but some people try it. And they failed buprenorphine, and they want to take methadone. So, and then there are people we talk about with naltrexone. How do you decide? And we usually leave it up to the individual to have a conversation back and forth of the benefits and the risks and make a decision, because if I decide to give you a medication that you don't like, you're not coming back the next day. And so for me, it's really about patient choice, safety, and the setting.
Especially if I'm stuck with the side effects for a month.
But to that point is, if you live in a rural area and there's no methadone access and all you have is buprenorphine, it's much more challenging about how do you get that methadone to that individual.
I think that our huge thing is what insurance does the patient have, because that's going to dictate what you have available to you. So for some insurers, like Vivitrol is not an option. The patient has to fail first on oral naltrexone, even if we try and write something like, well, that could potentially mean a death, because failing oral naltrexone, which we know is not effective, you know, there's good meta-analysis showing that, but that still exists in some parts of the country. Subblockade, we have the same thing, like where they want the person to be on a transmucosal first, even if, like, you know, we know that they're living in an unsafe house, they're living in a drug house where they have to share some of their medication in order to pay for their room. We would like them not to have to do that. We still get the same answer, they need to be on a transmucosal first. So the insurance, it really dictates a lot.
I'll just add that often the choice is made for the patients because few patients have a choice of medications. Most of the time they go to the only program available that only gives one medication. And this kind of silos treatment has been, really a major problem for our field. It's changing slowly. And I think some of the, especially in Vermont, some of the hubs offer all 3 medications. So then you can really talk about real choice. But, that's something in the future.
Patients have choices, and there are shared decision-making processes. Physicians and healthcare providers don't have choices in the sense that not offering medication as an option would really be tantamount to malpractice. A patient choosing to get treatment without medication is their choice, provided they're provided the appropriate information about the risks of death and overdose, et cetera. I think we don't have great predictive tools in terms of here's a patient, they aren't on medication at all, they want treatment, what do we put them on? Dr. Brooklyn's developed this wonderful 21-item questionnaire that can help try to, can you be managed in a spoke or should you be in a hub? The American Society of Addiction Medicine has a comprehensive package, not just for opioid use disorders, addiction in general. Should someone be in an office space versus an inpatient? What are all the bells and whistles that need to be added? None of these have been validated for opioid use disorder. So we really just don't know. There are things, however, as we see some patients, we know because of the antagonist property of naltrexone and the partial agonist property of buprenorphine, are going to have a hard time starting a medication. They're on opioids, they haven't reduced their tolerance, they aren't in withdrawal, they aren't stopping long enough. We see from the Josh Lee's paper, comparative effectiveness of sublingual buprenorphine to extended release naltrexone, that more than 20%, actually nearing 30% of the patients randomized to extended release naltrexone couldn't even get that first shot because of developing enough time away from the opioid to avoid the withdrawal. And that's really what Dr. Basaga's research is doing, is trying to figure out if there are ways to speed up that process or ease it. So there might be some predictors just in terms of whether someone can even stop their opioid long enough to be induced. Basically, anyone can be induced on methadone. You don't have that barrier. But it's a little bit more challenging, and it's more a work of art than science at this point, the induction strategies for the other medications.
Just a quick point. Sorry. The patient preference, because the EXPOT study comparing buprenorphine with Vivitrol have shown that patient preference did not really impact on their outcome. Again, both medications were equally effective, and patients who prefer buprenorphine upfront versus extended release naltrexone did equally well. So when you have actually a plain level field, we're learning new things about how those medications are. There's a huge expectancy, systemic, structural reasons why some medications are used and how.
Okay, anything else we know about patient preference or who belongs in what? We're stuck with what do we know, not what do we think. So anything else we?
Small studies, nothing really. So the big studies, the HEAL, the CDC studies, may not randomized, but hopefully we can learn something. Yes, so we need the large studies like the one that we've heard about, and as long as they are randomized and we can look at the preference, then we can probably learn about that. But at the end, probably will not matter. I think so, if we educate patients properly.
It seems like people are voting with their feet, though. Your slide said 2 patients in the entire miss of Vermont were on Vivitrol, and also in, I think it was Josh Lee's study of Rhode Island, there were thousands of patients in incarceration, and like 2 out of 1,000 chose the Vivitrol. I think that as a person with a former opioid addiction, there is a real factor, like this is going to block my natural endorphins. Like, I already feel like crap. Why would I want to block natural pleasures on top of the horrible experience of completely changing my life? And I think, some people experience depression, some people experience anxiety, some people experience extreme anhedonia. Unless we're out front about that's a real possibility for some people and give people the option of like, look, this could work wonderfully for you. Human physiology is really weird, and some people who have been on opioids for years do wonderfully on an anti-opioid. But I think not, acknowledging that people have that factor is problematic.
Great. Okay, we're going to move on because we've got about a half hour to get through the rest of the questions. So, Jinza.
Great. So I'm going to push this even a little bit further. Yes, there's patient preference. Yes, there's shared decision analysis. Yes, there's the world that we currently live in and the way that we provide treatment in the different settings. But given all of that, and given the data, and given your clinical experience, should there be different tiers of medications, of first line, second line, or sort of preferred first line for these three medications?
So I think the goal is to do a really good individual assessment on each patient, taking into consideration how old they are, what their other comorbidities are, do they have a mild, moderate, or severe opiate use disorder with current physical dependence or without? I mean, if someone doesn't have a current physical dependence and has a mild opioid use disorder and is an adolescent, I really, as a provider, want them to be on naltrexone. I don't want to create physical dependence when there hasn't yet been or the patient isn't already. So I don't know that there's a good trial that supports that, and I know that there's buprenorphine for 16-year-olds and older, but we are seeing younger people who are addicted as the opiate epidemic has worsened. So I think that there's a rationale to think that way. I think also that because there is potentially more consequences with methadone in terms of side effects, that there's a logic behind trying a partial agonist before trying a full agonist, and having, I think Keiko did one of those studies to see if you stepped care approach. Because it's more than just the pharmacology that we have to remember. Going to a methadone clinic, especially for some people, is a very stigmatizing and detrimental event, where if someone actually sees you in that parking lot, you could lose your job if you live in the right part of the country, because it's that stigmatizing. So I think a little bit like that. And then, of course, if you have someone that's really, really severe and their choice is they have a strong preference, then I think we need to do that because the data don't exist.
So, I can just add, the evidence doesn't seem to support it. That's what clinicians, I think as clinicians, we would like to think that way, but the evidence doesn't really support any predictors, both for extended release naltrexone and buprenorphine. Everybody does equally well or equally poorly in the treatment. Treating someone who has not been sick for a long time, is not severe, makes a lot of sense, and I don't think that these people were in those studies, like adolescents, but everybody else, whether you had 1 year or 20 years of addiction, does equally, again, well or poorly in treatment. What I think we should start rethinking is whether there is a concept of stage treatment, and this is not a new concept. It's been Avram Goldstein introduced in the 70s, that you meet patients when they are, and as we know, a lot of people are interested just to survive, to be able to use drugs and live the life they want to live that. And is there something that we can offer them? And we can certainly offer them harm reduction strategy, maybe even self-injection sites as an entry to treatment. Low threshold methadone, low threshold buprenorphine will be the next stage. If they're ready to move up, they can go to comprehensive treatment program, methadone, buprenorphine, whatever, right? And if they want to move beyond that, if they want to stay on that, they can stay. If they want to move beyond that, naltrexone offers something different that some people may like, some people may not like. We start knowing a little bit more about the cognitive effects of, and clearly we know a lot about physiological effects of agonists. We know less about antagonists. There may be some differences that may be attractive to people. And we cannot forget that most patients want to be off medications. When you ask people, most patients want to be off medications. They're voting with their feet. Yes, they're coming off medications, right? Everybody wants to be off medication. The question is how to help them on this pathway so that they don't have to do it on their own without physician helping them through. And maybe if we had this kind of stage treatment towards the kind of abstinence and recovery, the kind of something that few maybe will be able to achieve, but still everybody wants it, that could be another way of of
Chuck's
doing that.
waiting.
That's
I just want to say very quickly that I was surprised by the results of that latest Josh Lee study because it was totally random assignment. To me, that means that some of the people who, on a random basis, got depot naltrexone, I wouldn't have put on it in the first place. It shows they can do well because the major variable in that study, I want to emphasize, it was the smartness, the training of the physician who knows how to detox. In my place, we get 90 to 95% onto depot, just like 4 of the sites. The other 4 sites were just bad, but I'll bet you I could train them to get 95% as well. So what I do is I try to get the patient to be my ally. We work together, the patient and I. And I try to tell them what the benefits are. But as Adam just said, most people ultimately want to be drug-free. They don't want to stay on, like some of my patients, on methadone for 20 or 30 years for the rest of their lives. I mean, that is happening. That's what happens because it's really hard to stop an agonist. And so I tell them it'll be easier for you if you go on Suboxone or methadone now, but it'll be hard for you if you want to try to stop later. If you want a happy ending, put in the effort to start on an antagonist. And if they have some kind of skill, some possibility of getting a job, I mean, that's a very important part of the evaluation. If they've never finished school, if they're just not likely to do well occupation-wise, don't put them on naltrexone. But if you think that they have a hope of becoming self-sufficient later, then an antagonist, I think, gives them a better chance at eventually getting off of medication.
Well, I just want to jump in very quickly with that and just say that, like, people want to come off methadone often because the system is so horrible, not because the medication is horrible, not because they're having side effects. Like, if you were in a sort of chemical parole, you would want to get off it as fast as possible, too. So I think it's important to recognize that it's not just the pharmacology there.
Okay, Michelle, and then we'll move on to...
Right. I think I have a lot of patients who don't ever want to come off of buprenorphine because they've just gotten their life back to a place where it really never was for them, and they're very grateful. And I think part of it is because of how they're treated. And so I think a lot of people start just because of all the stigma and the way they're treated when they come out as having an addiction or opioid use disorder. But there are a lot of people who, and they don't need much more. So I have a lot of patients that really are just getting a prescription and encouragement, some basic supportive psychotherapy, and they are doing incredible things. And these were really people who had very severe opiate use disorder and psychiatric comorbidity and legal problems that, yeah.
Okay. Anything else we know on staging or a tier system? Anything else we know from the literature that we need to say before we go?
There are a couple genetic studies, right, that look at African American, European descent, different markers for whether or not they're going to respond to buprenorphine and methadone. And maybe, Gavin, you could just chat about that for a second. You're probably more versed in it than I am.
Well, just
Can I just mention that? So I am going to cut this off at 12:45. So not everybody has to answer every question.
I'm going to say yes to Dr. Carroll's question. We do know about low threshold access. So that doesn't have all of the requirements and bells and whistles. We know that's very effective low access to treatment. What we don't know are all of the added bells and whistles, benefit plus. We know a little bit from work that Chuck's done on that.
Okay, I think we're okay, Dr. Leschner. I've got Walter Scott, but we'll see, but I've got Walter next.
First of all, as a patient and an advocate, this is a dream panel for me, so I want to thank you all for being here today. But my question is really for Dr. O'Brien and Dr. Bart. Dr. O'Brien mentioned a couple of times if you want to have a happy ending, go on an antagonist. And Dr. Bart seems to have a different opinion. He seemed to say that why tell people to get off the antagonist if they're doing well? Could you guys respond to that?
If the patient, I think you can educate the patient. Right now, we are in this kind of a maintenance phase of thinking about methadone and buprenorphine. When I first got into this field, everybody thought methadone would be a temporary thing. And that's why I told you, I tried every way. You can look at the literature. I mean, it's all published, various ways to detox. And it's not easy, and they keep going back anyway. So I think, but at that time, the whole focus was on how long can you keep somebody on before it damages their kidneys or something like that. It doesn't. It's so, and we also fought out in court that you could drive a subway, there's all sorts of litigation. And so Gavin is right, there's no need to stop. And people started saying it's like insulin for a diabetic. But the truth is that if you want to do that, that's a patient choice. But if they ultimately hope to get off, they should know that once they start on an agonist, it's going to be very difficult sometime down the road, maybe years later, when they try to get off.
Thank you, Walter, for your question. I'm an internist, I'm not a psychiatrist, and so your question really resonates with me because we know aspirin reduces risk of death after myocardial infarction by 1/3, but we don't talk to our patients about what is your exit strategy? How are we going to get you off of this? Same with heart failure. When your injection fraction is less than 35%, you should be on an ACE inhibitor. There are some cardiomyopathies where the ejection fraction ends up improving and going back to normal. We don't say, hey, it's normal now. Let's stop that medication. So it's confusing to me. And yeah, we have to admit, it sucks to be on a medication. No one wants to be on a medication. But why do we as providers treat this differently? And yeah, ultimately, it's a patient choice, and we need to make sure that patients are aware of their increased risk of death if they were to stop it. And yeah, there are strategies to help them get off of it, but too often the stigmatizing language within healthcare is, when are you going to get off this stuff? And I mean, I can think of one of my buprenorphine patients I've been seeing for 12 years, and initially he said, I want to get off of this. And I said, well, do you also plan on getting off of your antiretroviral medication for HIV? Oh, no, that's keeping me alive. Why do we have this disparity? Healthcare providers with education can help with that.
I mean, that's important, but Gavin, let me ask you, how many patients with diabetes you think with them about going from diabetes to oral to diet-controlled sugar blood level? Whether this is at all even part of conversation or not.
It's a great analogy because we have the exercise and diet and portion control of diabetes. Behavioral portion control, really important. The natural history of it is there are people who control their type 2 diabetes with diet and exercise. Now, because it's generally a disease that has later age onset, most people don't live long enough for the natural course, but after about 20 years, there ends up being islet cell and insulin resistance returns, and it's very difficult to have long-term sustained remission of diabetes. Plus, the risk of the return of an elevated hemoglobin A1C, which can gradually be detected and the treatment can be restarted, is very different than the risk of you end up 2 years later after stopping your medication where there's an 80% chance of returning to opioid use, even if it's not DSM, full criteria, and the risk of dying from an overdose. They're very different scenarios.
I just want to add that in the presence of fentanyl, which seems to, normally heroin overdose mortality was 1% to 3% per year. I think Nora was saying earlier that it was more like 5% per year now. In the context of fentanyl and carfentanil and all of this other stuff, the calculus has to swing towards staying on because one mistake can kill you in this situation. And so, I think the heck with an exit strategy. I want to avoid dying of overdose.
Okay, I think the next one.
I'm going to ask Dr. Bizaga to weigh in, because I was a little bit confused about the logic of the that it's a myth that the overdose risk with naltrexone, injectable naltrexone specifically, because it seems that I don't think we have the data. If we have the data to support that assertion, then please let us know. But I don't think we have the data for that. And on the same slide, you mentioned that dropout rates are higher. So if you have dropout rates that are higher in an individual with no tolerance, it would seem to me that the logic would be that overdose risk is there. So can you just walk us through that?
I didn't have time to go into details, but obviously this is an excellent question. The point I was trying to make is for all of the medications, if you're staying on medication, the overdose risk is lower as compared to being off medication. I think most of us would agree with that, right? No question. Then the issue is what happens after you come off medication and why you come off medication, and whether some medications may be more likely that people come off versus the others, right? And there are differences between the medications, right? Clearly there is this, when you're taking everyday Suboxone, you clearly feel very quickly when you're coming off and you take the next dose. You don't feel that with injectable buprenorphine, although you feel somewhat. You don't feel that at all with injectable naltrexone. And that puts you at risk of being overly confident. Now, we don't fully know what happens, what's the trajectory, what happens from the time you come off medication and when do you overdose. All we know that most of the time people who come off medication have increased risk of overdose, right? The mortality, the question was, I'm sorry, that in terms of retention is comparable.
Just if you're coming off of the medicine, if you're more likely to come off of the medicine, and we know that off of medicine equals higher risk of death.
But you're not more likely. So the retention rates are comparable except for methadone, which seems to have a higher retention rate, right? So the question is, what do you compare to? Could you compare to another medication, or you compare to no medication?
I see.
Most of the cases, there are certainly cases of people dying all the time, probably more people who were treated with buprenorphine because more people were treated with buprenorphine, right? Most of the deaths, we don't know when they occur. They seem to occur much later, which is consistent with a disease course that people relapse not immediately, except for when they are detoxed, but later, people who've been stable. So I think there is a lot that we don't know. And you're right, those are rare events. It's hard to study without a good data set.
And similarly, then, using that logic, just to follow up, I don't think we have any data on the subcutaneous buprenorphine preparation either, because it's
in like 500, I don't know how many pages.
Infrequent use.
Yeah. But we have numbers, Adam.
Just to, because as Adam says, it's hard to know because there's so many variables, like the higher dose of fentanyl or carfentanil may make a difference. But I can tell you of 307 parolees in the study I published a couple of years ago, 5 sites on the eastern seaboard. The comparison group had 7 overdoses, and some of them were in areas exposed to fentanyl. The depot naltrexone group that got 6 months of treatment and then 12 months of follow-up, so you had an 18-month exposure, there was 0 overdoses versus 7. So again, there's so many, it's, I can't guarantee it's always going to be that way, but the other studies that I know of depot naltrexone also show fewer or 0 overdoses. So it means that you can overdose, but it's going to have to be a much larger dose of agonist.
So you just mentioned the subcutaneous buprenorphine too. I think those are really, we don't know, but they're really exciting, and I think they hold a lot of promise. Subblockade, is long acting, and is even after the month is still detectable in the urine several weeks to a month afterwards. So even if someone misses their dose, are they potentially still protected? So I don't think we know that answer, and is there gentler withdrawal because the levels are going down more slowly, and the same thing potentially with the with probufene, although you start with a lower level too.
So this question is for Dr. Brooklyn. You gave us a charge to replicate what Vermont has done. My question is, what is the distance between those hubs? And also, how many patients are each of those hubs managing?
So just to make sure I understand, you want to know the distance between hubs, and then what was the second part? The number of people at each one?
Yeah.
Okay. So remember, this is a regionalized system of care. So if there's a hub, all the community providers are linked to that. So let's take Chittenden County, largest county in the state, 125,000 people, probably 40 miles distance from one end to the other. The hub is located in the center, so the maximum distance someone would have to drive would be 20 miles. But scattered amongst that county are 50, 70 buprenorphine providers. So the goal is really to integrate this into primary care. We want a lot more people in the spokes than we want in the hubs. If it turns out that you need to be on methadone, then yes, you have to drive. Medicaid will pay for you to drive. The longest distance you may have to travel is probably 60 miles one way up in the Northeast Kingdom if you had to do that to get to the hub in Newport. We're actually working on this project where we're giving people these devices to take home with methadone in them, and then we're recording them taking the medication home to actually deal with that very problem. But the issue is that the distance can be significant, and there's Medicaid funding. Unfortunately, we have to spend Medicaid funding to help people with transportation if need be. So to that point, there are a lot of people who are in a spoke who the doc says, I want you to go to the hub because I think there's diversion, you're using cocaine. And we're working hard now with the MAT teams to try to keep those folks embedded in the spoke because there's a dropout. There's a potential dropout where someone says, I'm just going down the road to my FP, my family practitioner, getting buprenorphine. Now you want me to drive 30 miles each way to get my dose. That could be a significant roadblock. So to that end, we do double, triple dosing strategies with buprenorphine. If people, they can come in every other day and dose or every third day and dose is a strategy around that. So we recognize that the distance is an issue, but we also know that for people who want to stay in treatment, that option exists versus I'm done with you, I can't take care of you anymore, see you later. Yeah.
Distance plays a huge issue, but the other aspects to replication that I think are going to be really important, and as Dr. Brooklyn mentioned, is Vermont's a Medicaid expansion state. That makes a difference. And then when we look at Vermont and we look at Massachusetts with the LaBelle's model of integration of primary care, these are in federally qualified settings, and the reimbursement structure is dollar for dollar. My safety net setting, we get 36 cents for every dollar we bill. So the financial sustainability of a hub and spoke model doesn't work in the same way. So the replication also needs to be in non-FQ type settings.
Thank you. I'm learning so much. I can't tell you how grateful I am. So I'm a basic scientist who's been studying opiates in the brain for many years. And I'm having a hard time wrapping my brain around some of the apparent conclusions. And I think, therefore, I must be missing something. Because what I'm hearing is that an agonist, an antagonist, and a partial agonist are doing the same thing. And it's probably not what you intend for me to think, but that's sort of what's coming out on the surface. So I am taking this to mean that you have at least one criterion where I would understand it, which is that those drugs all occupy opiate receptors and therefore get in the way of the abused substance and make it less likely that the abused substance is going to be killing you. So I get that part. But then beyond that, I'm having a hard time understanding or believing that they are interchangeable. And so I need your help to understand how we can put more granularity. For example, if you're taking somebody who is 18 or 20 and you intend to put them on a drug for decades, that's going to change their brain. And it's going to change it in very different ways, depending on whether it's methadone or naltrexone. And I feel we need to think more about that. So can you help me with that a little bit?
So this is probably a special symposium on that because there's so many layers, right? That neuroscience. I think that there's a lot we don't know. You know, what is long-term abstinence on medication, on agonist, long-term abstinence on antagonist, long-term abstinence without any medication? You know, is it the same or is it different? You know, how the brain...
I bet you it's not the same.
Right. So how the brain health, you know, all the functioning of the brain are contributing to this state of presumably health, right? Long-term abstinence, if that's the goal. There's a lot we don't understand. We probably need help from you. How much of because it doesn't make sense. You block 100% of the opioid receptor, still most patients are able to experience everything else as if nothing was blocked. Wow. It's not like you block dopamine. It's not like you block dopamine, and clearly everybody with a blocked dopamine is not normal, right? Everybody feels very, very different. Here, you may have some patients with probably some genetic variant, they will feel that. Most patients feel much better. Now, much better comparing with taking heroin every day. We don't know what is the ultimate, baseline with someone who has not had. But, it is truth. And without looking at neurobiology, there's a lot of questions that we cannot really answer. The fact is that people have less cravings, use less opioids, staying in treatment, taking the medication. And when this happens, they can make all the other progress in their lives, right? Without being abstinent from opiates or actually other drugs, it's very hard for them to make a progress in their emotional health, social involvement, everything else.
Can I just say briefly, I'm having thought about the neuroscience of this for a long time from having played with my own neuroscience. It seems like different things work for different people, and so that one person, it will be hell on an antagonist. I spoke with a young bass player who, when she got on Vivitrol, she didn't want to play music because it just didn't do anything for her. It was the joy of her life before that. Now, I have also spoken to people who got their life back on Vivitrol. I've heard people who take Prozac, and it is the most depressing experience ever. For me, Prozac actually makes me function. And so I think what we're going to learn is that this is about different people responding to different drugs, because I don't think that it is the same for everybody. And it's quite clear that opioid receptors genetically are hugely varied in humans, and et cetera.
So I'm a reflection of my training, so this is somewhat parodying Mary Jean Creek, which is the indication that people with opioid use disorders have a relative opioid deficiency. And that can be viewed specifically through the hypothalamic pituitary adrenal axis in terms of stress responsivity. And with specific chemical probes of that axis looking at response to ACTH and cortisol response in the blood to various stimuli, we can denote differences between people with substance use disorders and those without. And well, there's not much of a difference between those with substance use disorders across the board in terms of HPA axis activity. We can see the effects of opioids are fairly unique on that. So acute acting, heroin, fentanyl, et cetera, will suppress HPA axis activity. Being on medications like methadone and buprenorphine, in terms of those same external sort of stressors, chemically induced, standardized stressors, for the most part can help normalize those responses. Now, we haven't directly linked that to a clinical outcome, but it's an intriguing neuroscience perspective. Now, an opioid antagonist, give it to a normal volunteer, ACTH and cortisol go up, just the opposite of what an acute opioid does. So it's an intriguing process to think from a neuroscience standpoint of naltrexone acts in the opposite direction on HPA stress responsivity than that. But what we haven't done for the extended release, at least not that I'm aware of, maybe Chuck, you know this, is oral naltrexone. We know the effect of it on HPA axis activity. I'm not so sure it's been adequately studied in the extended release version of what are its effects on HPA axis response to stressors and how that might be different in people who are being treated with opioid use disorders.
Okay. I'm going to cede my question To Dr., oh, you sure? To Dr. Hurd? So I'm this one, 4 minutes to lunch. All right. Yeah.
Doesn't do justice to this question. This is complicated questions and we cannot really solve this, but this is important questions, absolutely.
So I'm sorry, but related to that, are there placebo trials with these studies?
Of course.
Yeah, okay.
Of course, there's all placebo and randomized trials that show that we cannot really predict which people will do well on which medication, which speaks against, but it doesn't mean that there isn't a genetic profile of someone who is a responder, but just, we need much larger samples to show that.
But there's also, like, every time anybody wants to study, does something block social pleasure, they use naltrexone. There was a recent study of ketamine that showed that it doesn't work in depression if you use naltrexone. It is a common thing to use naltrexone to block pleasure in normal people, so it is a real issue.
That's not true.
Okay.
That's not, naltrexone is an effective treatment.
Right.
I just want to emphasize that pharmacology does matter here. So even if the genetics is there, the dosing does matter for blockade.
Right.
And so for some people, it will not block all of the receptors, and it depends on the affinity of the agonist and your environmental whatever.
Naltrexone is used to treat many psychiatric disorders. And it's
All right,
not
we're going to have to, I know.
people with regular pleasure.
Are you stopping us, or are you letting us go? I get my one question. This mine is a softball. Somebody, I think it was Gavin, who talked about measurement-based care. Can you give us one pithy minute so we can eat on measurement-based care?
Oh, God, that's so much pressure. Well, I mean, I think one of the issues we have, and I'm not going to give the solution, is when we're going to talk about opioid use disorders, what's the outcome? I mean, all of the studies we've been looking at when we talk about is we look at retention and treatment. So we can tell you lots of data about retention and treatment, but retention and treatment isn't the same as saying is drug use decreased. But when we look at, Cascudis did this fascinating online survey of 9,000 people who were self-described in recovery, and what is your definition of recovery? And not using drugs didn't show up in the top 10 of those definitions. So if we use drug use as the criteria of outcome, is the urine positive or negative, that might not be good. So how do we do something that is medically appropriate? Because as a physician, like Dr. Loeffel said, I don't want my responsibility to be that the person has to be spiritually grounded and employed and be a good parent. That is part of recovery, and it's important. It's important, but it's beyond the scope of what medicine can do. So what can we as physicians do? And if we have, again, psychological profiles and indicators of well-being, however someone like Dr. Carroll might define that, then we can help guide the caretakers of, hey, based on this measurement, time to shift approach. And we've done that for depression. Can we do that for opioid use disorders?
All right.
All right.
Why did we miss the psychotherapy?
Remission is a criteria. We could go on. We should go on. There's much that we have to
So
do.
with all respect to DSM, it's not the Bible. Maybe there are better.
But I do want to. I do
success.
want to thank an extraordinary panel who have given us a lot to think about. It's been very inspiring and hopeful and a little scary in some respects as well. But you were all just extraordinary, and thank you so much.
So let me. I was going to say what she just said. I also want to point out to those who are speaking later in this workshop, the bar is very high between the federal group and this group. You're potentially in a lot of trouble. Anyway, this has been wonderful. Okay, so my instructions are, the committee is meeting in room 103. Everybody else, do not steal food from other rooms. Rumor has it that some unnamed people were doing that. We will be arrested or something. But there is a cafeteria on the third floor. And please do feel free to eat there. If you get there soon, you'll beat the lines. Okay, thank you. 1:45 on the nose.